So the current model has seen us remain fairly constant with the funding flowing to the organization delivering the care. We haven't commingled the budgets at this point. What we're now doing is talking with the policy branch of the ministry and our partners in places like the CCAC and the LIN at saying, what populations at risk might we want to experiment with? And how much flexibility might we have in saying, could we see the money follow the patient? We're not being shy about asking for forgiveness rather than permission, and really saying if this makes sense from a quality perspective and from a patient care perspective and from a clinical provider perspective, let's try it. And if it works, then we need to take that forward, demonstrate why it works and how it works. Currently, the economic backdrop of really the world, but Ontario included in the world, is a challenging one. And so we are not only need to be focused on how do you deliver quality of care, but how do you deliver quality of care with significant cost controls, which need to be in place, both because of cash flow from a government perspective, but also longer-term affordability. So for our system, universal access is a very important element of the Canadian system and of the St. Joe system. We want to work to try to preserve that by saying we're as efficient as we can be. We have the lowest cost, high quality provider doing the work, and we have high degrees of patient satisfaction with good markers that can be held up for comparison and say, how are we doing relative to our peers? And increasingly engaging clinicians in asking the question, why am I a top-end provider, a middle-mark provider, or a low-end provider in terms of our performance? And what are others doing better than we, or what are we doing better than others that can inform us or hopefully inform our peers as to how to migrate to a higher level of performance?
So you're talking about looking internationally across jurisdictions
Absolutely.
To learn from the best and bring those lessons to Ontario?
Absolutely. And also, I mean, to complement the Change Foundation, we've worked very closely with the Change Foundation. A number of the initiatives the Change Foundation has embarked upon have looked at high-performing health systems. So what can we borrow from that? Right. And what are the barriers? Clearly, at the moment, one of the big barriers is cash flow between sectors. And much of the legislative framework that sees, for example, the Public Hospitals Act isn't all that well aligned with the Long-Term Care Act. In the Public Hospitals Act, it says when your acute care is done, you should leave. In the Long-Term Care Act, it says you should have a choice about where you go. So if you can't go home, but you need to leave a hospital, which act will supersede the other?
Right.
That seems to be part of the challenge with our ALC problem.
Right.
So we're not only identifying best performance, but also perhaps best legislative direction is something else that we're trying to liaise with government on.